Good afternoon. Welcome to Symposium 14, which is entitled Enough is Enough, Time to End Preventable Mortality Among People Living with HIV. My name is Haile Jesus Getaun. I work with the Global TB Program of WHO. I'm co-chairing this session with my colleague Rita Delodlo from the Union. This session will discuss despite our success, particularly for the last decade, in preventing mortality among people living with HIV, because of the scale-up of ART, as well as all our efforts to strengthen our programmatic collaboration between the TB and HIV programs, we still see the mortality TB as the leading cause of mortality among people living with HIV. And this session will discuss why is that happening and what we can do to prevent it for this unacceptable cause of death among people living with HIV. And with that introduction, now I will ask my colleague Rita to introduce the first speaker.
Thank you very much, Haile. Good afternoon, ladies and gentlemen, colleagues. It's my pleasure to invite Dr. Meg Doherty as our first speaker. She has been the coordinator for treatment and care in the HIV department of WHO Geneva since 2012. She is a trained infectious diseases specialist as well as an epidemiologist. And she leads the team that developed, for example, the WHO 2016 consolidated ARV guidelines. She will take us through the first presentation in this afternoon symposium, and it's entitled HIV-associated TB Mortality, an Irreversible Truth.
Okay, thank you very much. And I also know right next door to us is a competing session on TB mortality. So let's see. They have the new evidence. We have summarized information, and potentially we're going to help find some goals of what we can do to make this change. And I've been given a very, interesting title or provocative title. Is this an irreversible truth? And I'm going to try to tell you, no, we need to change this, and we have the capacity, and we actually have the policies in place to be able to make the change. I have no conflict of interest to disclose. So briefly, I'm going to talk a bit about our current strategies to end HIV and TB mortality. Both of these are targeted, and we have goals through the UN through 2020, 2030. And then I'm going to speak to the question. We have HIV-related TB deaths. Can we reverse the trends? And I'll show you a bit about what we see in the trends, and then start to talk about some of the solutions, of which you'll hear much more during this session, which will be finally concluded with a session on the guidelines from WHO that Annabelle Baddeley will have in this afternoon. So, unfortunately, I'm also on the HIV side, and we all work very well together, but sometimes my slides have the bias of HIV. So I'm starting here with the fact that we have an HIV strategy up till 2021, where we are endorsing and trying to obtain 90% of people with HIV tested, 90% of those treated, and 90% of those virally suppressed. And what you will see below is the most recent evidence towards where we are in terms of attaining those. And we're pretty far away in terms of 90% treated and 90% virally suppressed globally. And I think part of what we need to do is to improve this section is around mortality, reducing mortality, ensuring that we get people into care early, start treatment early, and certainly the majority of the mortality we're seeing with HIV is related to TB. So what we do have, too, in our health sector strategy is by 2030 for HIV, we plan to reduce HIV-related deaths to less than 500,000. We're at approximately 1.2 million right now. And additionally to that, we need to decrease the number or the percentage of HIV deaths related to TB or TB-related deaths by 75% in the similar time frame up to 2025. So we have a lot to do. So where are we? In terms of ARV scale-up, you're probably well aware, in the latest UNAIDS global report in July, we were at 17 million being on treatment. And with that, we have seen, a subsequent decline in mortality. But hidden in there is actually a very stable incidence, and what you don't see is the denominator. And what you don't see is we have an increasing prevalence, an increasing burden, and lots of people dying. So our deaths are declining, but only when we start to look very far back and start to say, comparing it to 2000, 2005, et cetera. But more recently, we've also had some plateauing in that area. So what is WHO doing? From the HIV and TB side, we put out very new guidelines in 2016 to say that we should be treating everyone at any CD4 count, and that's TB patients as well, anybody with TB as well, and certainly we want all persons who are of HIV and TB to be on antiretroviral therapy. And what we see is the uptake of this policy for treat all is going pretty well, with colors in green indicating that the policy is taken up. But the lighter green here shows that we're actually not yet implementing this at the levels that we need to have the impact. So countries that are in a lighter color mean that they're uptaking or adopting the policy, but not yet implementing. So we have quite a bit of work to do on getting countries to fully implement the policies that we already have well established. We also follow the policies around TB and HIV collaborative activities. And one in particular is the ART delivered in TB clinics and TB treatment delivered in ART clinics. It's a two-way street here. And what we see is we're still only at around 40% of those countries in low and middle income countries that we're prioritizing who actually have the policy on the books. So we then know that the downstream effect of implementation is less than ideal. So when we follow the numbers of persons who are started on ART among notified TB HIV positive cases, we can see an increasing and positive trend, which is great if we just look at this slide. If we look at this slide, which is now highlighted in the TB report that just was launched this month, we actually have a much greater gap, almost a 60% gap, to try to identify those people who actually have HIV, don't know that they have it, and have incident TB and don't know that they have it. So here, we're doing quite well. We're almost reaching the number of reported HIV positives with TB, but it's the case finding, case detection, both on the HIV side and the TB side, that need to be stepped up. So what are parts of the challenge for this? Many challenges are late presentation as well. We are seeing, despite the fact that we have increased the eligibility criteria, we still see the majority, or not the majority, but at least 1/4 to 1/3 of patients in different parts of the world coming in with very low CD4s. So if they're coming in at low CD4, that they really have a greater risk of them potentially dying early from TB or undiagnosed TB. And this is evidenced in a review that we did at WHO as part of our guideline process. And we looked at TB not only in hospitalization, but also in causing death once hospitalized. And from this meta-analysis that was conducted by Nathan Ford, what you'll see is overall for adults, there's a very high rate of hospitalization as a cause due to tuberculosis, as well as for children. And then when we start to look at mortality among those who are hospitalized, tuberculosis is approximately 30% of the time the cause of death once persons are hospitalized for both adults and for children, with slightly higher for children. And we also know that this increase of tuberculosis is higher, and it occurs still even when people are on ART. So getting onto ART is not the only solution here. It's often related to late diagnosis, advanced immune suppression, so even if one does get the ART on, it may be very difficult to ensure that that person does well. And also what we're seeing more and more being reported is suboptimal adherence and poor retention. In some of our studies of what we call our early warning indicators, we're actually seeing 5 years out some very troubling data around retention in care. And that too has an issue of people coming in and coming out of treatment. So what else do we know? We know, and I'm sure you're very well aware of this, of the postmortem TB prevalence studies that were recently reported by Stephen Long and Dr. Gupta. And what you see is that it remains quite high, that among those who are dying, about 45% of those cases are not diagnosed prior to death globally. And then if you start to pick this apart, we can also see that there are differences by regions, where the post-mortem TB prevalence is in the 40% in the sub-Saharan Africa, and even higher, close to 63% or proportion in South Asia. So we also know that some of those unclear deaths are likely related to tuberculosis and potentially to other diseases that we're not very good at diagnosing. What we do know in this new global report that was put out by WHO is around the treatment outcomes by HIV status. So in this cohort analysis, we have in red those with HIV and in blue those without HIV who have had treatment. And you can see that those with HIV have almost a 3 times greater risk of dying during their treatment period. And if we start to look at the relative risk of case fatality, or the same type of risk of those patients who have TB, who are HIV positive, and this risk can really vary widely from sort of 3 up here down to 1.2 by geography. And I think that's important because that probably gives us some clues as to how these different programs are actually implementing, getting patients onto ART early, and also what else they are doing in terms of identifying, case finding, and potentially even preventative therapy for TB. Lastly, I wanted to then talk a bit about what WHO is thinking about doing in the future. So how can we address this? And not only do we have lots of great policies and recommendations that Annabelle will talk to, and we'd like to see those implemented, we also feel that we need to spend a bit of time thinking about advanced disease and late presenters, and they don't always equal each other. And from this study that came out of South Africa, and this has been a major issue that South African teams as well as MSF teams have taken on, that you can see that on hospitalizations, out of 600, approximately a third are naive, and the most frequent clinical diagnosis is tuberculosis. But also you have people who are failing or have interrupted treatment who are also coming in. So we have to think of not only when people come in, but when people represent are ill and at advanced disease. And what we can see is this group is at high risk and follow-up to require readmission, and nearly 13% of them died. And the commonest cause of death is very similar to what we reported in our systematic review, 37% of them due to TB. So it's all saying the same thing. So what do? MSF has already started out with sort of looking at a late presenter screening package at the primary care level. So this would be for people who are diagnosed as advanced disease, a CD4 less than 200, which is similar to our CD4 that we use in our guidelines for advanced disease, and doing a package of screening with CD4, semi-quantitative, so one can say, are they high CD4, low CD4 quickly, a serum cryptococcal antigen test, a TB LAM test, and potentially drug level tests or toxo screening. And I think you could include in here an expert and potentially some other interventions with intensive follow-up for this. And many of you may be aware of the reality trial by Di Gibb that presented if you could take people who are very ill, both children and adults, with a CD4 less than 100, in an African setting primarily, if you give an enhanced prophylaxis package to this group without diagnosis, without lots of lab tests, including INH prophylaxis, B6 fluconazole for your cryptococcus, azithromycin for your antibacterial and antiprotozoal prophylaxis, as well as albendazole, that at 24 weeks, you see that there's, whoops, it doesn't like that slide, that there's an improvement over standard prophylaxis of just cotrimoxazole and IPT, where you get, with the enhanced, a reduction in mortality of approximately 8.9 and 3.3 lives saved for every 100 treated. Now, this may or may not work across the board, but WHO is going to be looking into that. And I think what we don't know is here, could this enhanced advanced disease care package really also help us to improve the mortality around these unknowns, which likely some of these are going to be tuberculosis, potentially other fungal infections that we're not able to diagnose, or bacterial infections. So, in conclusion, I think I've gotten to my 15 minutes. I think this is just setting the scene. We have unacceptably high rates of HIV-associated TB mortality, and this persists. Nearly 30% in the systematic reviews, as well as in the up to 40% in autopsy studies. We do believe this is related to poor case finding and advanced disease at first presentation or rehospitalization and representation. To address this globally, we feel like we need to fast-track these interventions to save lives, including implementing early ART, which not all TB patients get, early TB treatment and early TB diagnosis. And later this year, WHO will be recommending a package of preventative treatments to reduce both TB deaths and other deaths early on in disease. And lastly, I think after we hear Annabelle speak, we really need to work towards getting countries to implement our evidence-informed policies to reach our targets. So with that, I'd like to support the Step Up for TB. This is my one advocacy moment, so we'd like you to join on the campaign. And this is the campaign to get all countries to implement the WHO TB guidelines, including upgrading testing and treatment by World AIDS Day 2018. So if you haven't seen this slide yet, I'm surprised. I would imagine it's being presented in many different places. So hopefully you can sign up and support this effort. And I'd like to thank those who helped me, especially Annabelle, with these slides, as well as Hailey, who's here in the audience. Thank you.
Thank you very much, Meg, for the first presentation. Before you run away, I think we have to recognize your time consciousness by allowing perhaps one question at this stage. I do request the rest of you to note down your questions, because we have reserved 15 minutes at the end of the symposium. I can see somebody already at the microphone. Over to you.
This is Jerry Friedland from Yale University. I wanted to, this is sort of a comment but question also. Certainly treating TB and HIV as quickly as possible, this is in very sick, hospitalized patients with advanced disease, is critically important. But I wonder if in your investigations of the literature and also in other clinicians in the audience, whether there hasn't been enough attention paid to actually what people die of. They die with TB and HIV, but they die of renal failure, they die of severe anemia, they die of malnutrition, they die of dehydration, that is, the severe effects of very late-stage disease. And I don't think there's been enough attention paid to actually very aggressive management of very sick people. We focus on the TB and the HIV, but not the consequences of those diseases.
Yeah, I would agree with you, and certainly from my clinical experience, it's not usually one disease when people are very ill that kill people. There's multiple OIs that one could find, and certainly it's the sort of the multi-system issues that occur. I don't know if I can go back. Let me see if I can go back. In the review on hospitalization, we really did try to take a look at some of these other comorbidities that would run with HIV. And we had a very difficult time because I think it's all about how some of these studies around the world actually document death. And we had a difficult time looking and being able to categorize if it's renal as the primary problem or liver as the primary problem with an underlying of TB. So as you can see, we do have liver there in 6%. And I think certainly from the Temprano and the START trial, we know that bacterial diseases are not being identified, and probably a lot of this is pneumococcal and could be prevented with a pneumococcal vaccine, which is one thing we're thinking about. And yeah, so to say we haven't gotten it all, and I think because at WHO level, we have been doing the public health approach, and I think more and more we really do need to focus on how do we have standards of care in hospital as well.
Right, exactly the point. I think there are modifiable changes that might be makeable in the acute hospital setting that would improve mortality. Most of the mortality, when you see it in hospital, is very early on.
Yeah.
And a consequence of, and many things can be done to actually preserve life in that period of time.
Thank you.
Thank you, Cherry. Thank you, Meg. We shall move on, and please keep record of your remaining questions. Our second speaker is Dr. Salome Sharalambo. She's the technical director of the Aurum Institute, situated in South Africa. She is a medical doctor from South Africa, University of Witwatersrand, with a PhD from the London School of Hygiene and Tropical Medicine. We have got the pleasure to have you here this afternoon with us, and you will be speaking about perfecting the TB-HIV screening, diagnostic and treatment algorithm to ensure survival from tuberculosis in the people living with HIV. Over to you, Salome.
Thank you. I'd like to thank the organizers for inviting us to share our experience in TB-HIV screening, diagnostic, and treatment algorithms. And I'm going to be talking on behalf of two study teams, those of the X-Factor study and those of the TB Fast Track study teams. So as has already been shown by Meg, we know that TB-HIV co-infection is important, and that autopsy studies have shown that TB is a primary or at least contributory cause of death in people with HIV. We also know that as ART is started, there are very high rates of TB disease, especially in those patients. So since TB is curable, why are we not diagnosing TB and putting people on treatment early enough to stop deaths? So just first looking at the TB diagnostics, some of the issues that we have is that sputum microscopy is still the mainstay in many developing countries. We know that expert MTB-RIF has lower sensitivity in HIV-infected persons and also does not diagnose TB in extraprimary TB cases. It's also not a point-of-care test, and so results in significant losses to follow-up. The LAM test, although it's quite promising, has showed low sensitivity in the outpatients groups and even in patients with low CD4 counts. And although there's high specificity and evidence for improved outcomes in hospitalized patients, it is still limited in the outpatient setting. So our TB diagnostic tools have their limitations. In addition to that, we have to identify who is best to screen for TB. And we did this study called the X-Factor study, looking at the use of expert MTB-RIF in patients attending HIV care. This was done in a sample of adults attending for HIV care in 4 clinics in Gauteng, South Africa. And looking at the baseline characteristics of patients enrolled on this study, you'll see that in total we enrolled 2,600 patients who were on ART treatment and 906 patients who were about to start ART. And you can see there that one of the most important points on this slide is really the WHO symptoms at enrollment. So at a single clinic visit of patients who are on ART, 30% had one of the WHO symptoms. And in those starting ART, 38.6%. So you can imagine that if you are a nurse working in one of these clinics and you are told that every person who has a positive symptom for TB needs to be investigated further, you would be investigating 1/3 of your patients every single time. So generally, we have a problem that TB symptoms are very common in people with HIV. And so far, all we've been able to do is help people to say that these are people that need to be investigated further. but how to differentiate those that should be investigated with those that possibly don't need to be investigated at that moment. In addition, we know that our WHO screening tool is really a tool that has been devised in order to rule out TB rather than to rule in TB. And this is the performance of the screening tool in the X factor patients. And you can see that although the negative predictive value is very good, the positive predictive value is only 10%, which indicates that for each one that is for each 10 patients that are identified with a WHO screening tool, only one will actually have a positive TB test, which again makes it quite difficult for people working in these health settings and makes it difficult for them to determine who to test and who not to test. So our algorithms are also insufficient. WHO screening algorithm is for TB exclusion rather than for diagnosis. Once somebody is tested for TB and a result comes back, 9 out of the 10 patients are going to come back with a negative result. And then we have the problem of the test negative algorithm. And this is data from a trial called the Extend trial, which was an evaluation of a national rollout of Expert. And in this trial, we compared patients who were enrolled in sites that had access to smear microscopy compared to patients who had access to Expert MTB-RIF. And what you can see here is just the algorithm of patients going through the algorithm, and those that were identified to be negative, either at smear microscopy or through Expert, were then identified to see those with an HIV positive test. Did the smear negative or test negative algorithm, was the test negative algorithm followed? And you can see here that even in the microscopy arm, 67% of patients had no further investigation of antibiotics after a smear negative result. And in the Expert arm, 86% of patients had no further investigations. So what we can see here is that in both settings, there is a problem with adherence to the test negative algorithm. And unfortunately, in the Expert setting, it's slightly more of a problem than in the microscopy setting. So the problem is that we have poor adherence to the algorithm for TB diagnoses. But as we've already said, we're talking about large numbers of patients that have symptoms to begin with that are then put through this whole process. And we're really allowing the health workers to actually just decide at every point what they should be doing, because the algorithms that we've given them are basically saying they need to do so many extra investigations to identify a case of TB. In addition, we have the issue that has already been discussed in this session, and that this is data from autopsy studies that have shown that amongst 38 patients, the total number, sorry, I'm pressing the buttons crazily here. So the total number of diagnoses made, which is massive, and there's so much overlap between those that had TB and those with bacterial pneumonia or other bacterial infections or cryptococcal disease or pneumocystis carinii, which is an additional problem that TB is occurring together with many other infections in people with advanced HIV. So if TB is so difficult to diagnose, what about the idea of giving empiric TB treatment to those who are advanced HIV? So empiric TB treatment would be treatment that is given without bacteriological confirmation and where the diagnostic testing is unsatisfactory, but however the TB is likely and the risk of mortality is high. There are potential disadvantages such as drug toxicity, drug interactions, and missing other diagnoses as we've shown. So we need to target empiric TB treatment to those that are at highest risk. So this is one trial that has been done looking at empiric TB treatment. It's the Remember trial. And in this trial, HIV-infected patients with very low CD4 counts below 50, and no active TB were then put onto antiretroviral treatment and empiric TB treatment, and compared to a group that was not put on empiric treatment but was put on ART and IPT. It is important to note that in this trial, there was enough ability to investigate patients thoroughly and to exclude active TB in these cases. So in this trial, there was no additional benefit of presumptive TB treatment, the mortality was 5% in each group, and side effects were very similar in each group. And as you can see in the Kaplan-Meier curve, the mortality is very similar. So we looked at a trial looking at using a point-of-care TB test and treat algorithm to identify those who should be started on TB treatment early in a trial of ambulatory patients. So the hypothesis was that a management strategy for HIV-positive people, enabling nurses in primary care clinics to triage to identify those at highest risk of TB, to initiate empiric TB treatment rapidly and then followed by ART promptly, would reduce early mortality. The TB triage tool that we used was a positive urine lamb test or a body mass index of less than 18.5 or hemoglobin of less than 10. So this is the TB fast-track algorithm. We looked at HIV-positive patients with a CD4 count of less than 150. Firstly, just important to note is that patients with danger signs were referred immediately for care and were not included in the trial. TB symptom screen was done and the TB triage tool was administered. According to the tool, people were then made up into 3 probabilities of TB: high probability, medium, and low probability. The high probability of TB would be those that had one of the 3 elements of the triage tool. Those patients would be started on treatment as soon as possible and then antiretroviral treatment. Those with a medium probability of TB were those with none of the elements of the triage tool but TB symptoms. And these patients would be investigated further for TB, and then a decision would be made on whether to start TB treatment or to start antiretroviral treatment. And those with no symptoms and none of the elements of the tool were classified as low probability and started ART immediately. So the aim of the TB fast-track trial was that amongst HIV-positive adults with low CD4 counts to compare all-cause mortality at 6 months in patients managed with this TB fast-track algorithm versus routine care as per standard clinic management. So how did the triage tool work? So this is in the intervention arm. There were 1,506 patients enrolled. Of these, 46% were classified as high probability of TB, so they had one of those 3 of the triage tool, and a further 32% were classified as medium probability of TB. And then 23% had the low probability, so they had no symptoms and none of the elements of the tool. So of those with high probability, a very large proportion, 96%, were started on TB treatment. Those with medium probability, 45% were started on TB treatment, and there were a few in the low probability arm who were also started on TB treatment because we did a TB culture at enrollment, and some of the TB cultures actually came back positive. Looking at the mortality in the 2 groups, unfortunately, we did not see a difference in mortality between the intervention and the control groups, and this was in an unadjusted analysis and the adjusted analysis. And you can see as the Kaplan-Meier curve that the death rates in the 2 groups were very similar. One of the secondary outcomes was to try and improve enrollment to ART start. We believe that if we reduce the investigations for TB, we would then be able to start patients more quickly. And what we found that actually starting ART in the first 30 days, in the intervention arm, only 66% of patients were started, and the control arm, 72%. So what it seems like what happened was that there was about a median of a 7-day delay in the intervention arm in starting ART. And that could have been because people were already on TB treatment and there was a reluctance to start ART immediately after TB treatment. Sorry. Just looking at whether the tool was good at identifying those at high risk for TB. This is looking at the control arm and a simulation of the tool. And you can see that those who were classified at high probability had a much higher risk of dying than those in medium or low probability. So the tool was able to identify those at highest risk of dying, but was not able to prevent the deaths. So in conclusion, a risk assessment using primary care friendly measures can identify people at highest risk of TB and death, but our strategy of targeted empiric TB treatment although it increased the coverage of TB treatment, did not reduce the time to ART start, and it did not reduce mortality at 6 months. So our study supports the current WHO policy regarding empiric TB treatment. So the way forward is really to find a new, rapid, reliable test that can be used at point of care, to find improved algorithms to guide diagnosis of TB in HIV-infected persons, especially in this era of expert, and to improve the intervention to reduce deaths amongst those who have TB through either better management of TB and HIV, as has already been discussed, and also finding the other opportunistic infections. Thank you very much. I'd just like to acknowledge the 2 teams that have been involved in some of this work.
Thank you very much, Salome, for a very inspiring presentation. Can we have one burning question to her? Lisa?
From the Office of the Global AIDS Coordinator. Thanks for an excellent presentation. It's a bit disheartening, and I guess my question is if you have data on what proportion of your patients already had been in care or on treatment, because I do think increasingly we have to ask ourselves, why are they coming so late and so sick? Because I think ART is much more widely available, and so we're seeing more and more that it's patients who left treatment for some reason or never started even though they knew they were positive. So I was just curious from your study. Thanks.
Okay, so patients who were enrolled in this study were only patients starting ART, and we had specifically selected patients with CD4 counts of less than 150. So in fact, what we did find, I mean, a bit of a good news story was that it was actually quite difficult to enroll. We took longer to enroll than expected because the CD4 counts had gradually gone up from the time of planning the study to actually executing the study. In these patients, if they had previous ART, they were generally not enrolled, but very few patients actually admit, if they've not been to that clinic before, very few actually admit to having had previous ART and having fallen out of treatment. We found very few of those. Yeah.
Thank you very much. Thank you. Thank you, Salome. We will now move to our 3rd presenter this afternoon. It is Dr. Wenceslaus Katagira, who is a physician at Makerere University Lung Institute in Kampala, Uganda, and he is currently undertaking a 1-year Fogarty Global Health Fellowship with supervision from Yale University in the States. Dr. Katagira will be speaking about the role of presumptive TB treatment for improving survival in severely ill patients with HIV. Over to you.
Thank you so much, and many thanks to Annabelle, who invited me here to share our findings that we published in the Journal of AIDS. Again, special thanks to Luke Davis, who mentored me and put in a lot of time into mentoring and also contributed a lot to the writing of this paper. So as displayed, I'm going to be discussing our findings. The title of my presentation is Empiric TB Treatment of Severely Ill Patients with HIV and Presumed Pulmonary TB Improves Survival. I have no conflicts of interest to declare. Now, as a way of background, we already know that in high HIV prevalent settings, patients who have negative AFB smears and yet have TB symptoms usually have poor outcomes and high case fatality rates, especially because we don't have very good or highly sensitive methods of diagnosing TB. Now, recognizing the high case fatality rates in this patient group, the WHO released guidelines in 2007, and it was encouraging the increased utilization of empiric TB treatment by clinicians, especially of those patients who are at risk of death. And in these guidelines that I'll be discussing about later, they encouraged clinicians to pick out those patients who are at particular risk of death, those who have HIV and they have symptoms of TB, but smears have come back and they're negative, and yet they have physical signs of severe illness. Now, to pick out something from the algorithm, you see on the top that the patients we're talking about are those who have HIV. Those who have HIV have cough for 2 weeks or more and have signs of severe illness. and yet their AFBs are negative. So the recommendation at that time was to start empiric TB treatment and continue it to completion. Now, because at the time of the recommendations, research supporting these recommendations was limited, the WHO again called for operational research to try and test and evaluate the effectiveness of these guidelines. So what we did was to set out a study, and the objective of this study was to determine if empiric TB treatment of severely ill HIV seropositive patients with presumed TB is associated with increased survival at 2 months. This was the retrospective observational cohort study carried out at the Mulago National Referral Hospital in Kampala, Uganda, between September 2007 and March 2011. Our participants were inpatients admitted on the medical wards of Mulago Hospital who were presumed to have pulmonary TB. We included all patients who were HIV seropositive and who had a cough of 2 weeks or more, but less than 6 months. We excluded all those who had positive AFB smears because they were immediately started on TB treatment. Under procedures, for all participants, we collected 2 sputa, including a spot and early morning, and we did sputum microscopy, AFB smear microscopy, and mycobacterial cultures. In addition, we drew blood and did HIV antibody testing, and we also did CD4 T cell measurement. In addition, we also did a frontal chest X-ray. Now, our primary predictors were first and foremost if a patient had any sign of of serious illness, and these signs were defined by the WHO as the danger signs. They included a fever, defined as temperature of greater than 39 degrees Celsius, a respiratory rate of more than 30 breaths per minute, a pulse rate of more than 120 beats per minute, and the other fourth sign was inability to walk unaided. The other primary predictor was empiric TB treatment, which was defined as any TB treatment prior to hospital discharge and prior to receipt of any mycobacteriologically confirmed diagnosis of TB. Our outcome of interest was vital status at 2 months, and we did analysis, and in this we performed the Kaplan-Meier survival analysis, as well as the multivariate Poisson regression model to calculate the risk ratios and 95% confidence intervals. Now, as I move into the results, I show you a picture of the National Referral Hospital where the study was conducted. Now, the first figure is the enrollment flow diagram. And you can look, like you can see at the top, So, like we can see at the top, of the 631 patients who were HIV positive, presented with symptoms of TB, had negative smears, and signs of severe illness, 51% had danger signs. And unfortunately, of those who had danger signs, only 23% were treated. There was also a proportion of those who didn't have any danger signs who were treated. When you look at the baseline characteristics certified by empiric TB treatment status, you see in the first 3 rows that overall this was a very young population. And the age in between the two groups wasn't different, 33, the median age 33 and 32. And this study population again had advanced HIV immunosuppression. And you can see, the median CD4 was 72 and 86 in the 2 groups. If you look at the last 2 rows, you see that danger signs were common in the group which was treated, and also mycobacterial cultures which were positive were also more in the group which was treated. Now, this figure shows you the survival of severely ill patients with presumed TB, stratified again by empiric TB treatment. On the y-axis, you see the cumulative survival, and on the x-axis, you see the days since enrollment. On top is the group with danger signs, which was treated, and on top, and just below that is the group with danger signs which is not treated. You can clearly see the divergence that starts very early in follow-up. And it keeps on increasing as you go along the days of enrollment. And you can see that just before 2 weeks already, only 5% of those who were treated died, and 46 died within the first 2 weeks of enrollment. So this difference continues throughout the days of enrollment or the days of follow-up since days of enrollment. And we found this difference to be statistically significant with a p-value of less than 0.001. And it gave us the number needed to treat of approximately 6 individuals treated to save 1 additional life. In summary, it shows that the cumulative survival of patients who had danger signs and were treated was higher in the group which was treated compared to that which was not treated. Okay. Now, after adjusting for the relevant covariates, we found that patients who had danger signs and were treated had a 17% adjusted absolute risk reduction in death at 2 months compared to the group which was not treated. And the relative risk difference was 44, giving us a p-value again of 0.02. However, we found no mortality benefit of treating a patient without danger signs. And that was both in terms of absolute and relative numbers. So our study had a number of limitations. First and foremost, it was an observational study. So treatment decisions were non-randomized, making it susceptible to biases like confounding. And interestingly, we saw that, among the group that had danger signs, some of them had TB and others didn't have TB. And once they were not treated, the mortality in both groups was similar. Quite interesting. The second limitation was that we had about 12% losses to follow up in the first month, and this increased to about 16% in the second month. But when we compared, the losses to follow up were not different in the group with danger signs and without danger signs, and also in the group which was treated and that which was not treated. So we didn't think it had any significant impact on our results. Then the other limitation was that we included only 3 danger signs. We didn't include the 4th danger sign, which was inability to walk unaided, because it was not routinely collected in all participants. However, in a small subset of participants where it was collected, the 4th danger signs did not increase the proportion of patients with danger signs, because all the participants who were unable to walk unaided also had at least 1 other danger sign. So again, we didn't think that this significantly affected the proportion of those with danger signs. Lastly, the study preceded guidelines which recommended early ART initiation in TB patients with HIV, as well as other TB diagnostics which came on after the conclusion of our study, including GeneXpert, MTBRIF, and urine LAM. So we don't know exactly by what percentage ART would have increased survival in this population. As I conclude, I will leave you 3 conclusions we had. Number 1, the rates of empiric TB treatment in our study population were really low, 23% only. Then, however, in the group of patients who were treated, empiric TB treatment dramatically reduced mortality. And we think that for patients who have HIV, suspected to have a TB, smears are negative, and have signs of severe illness, we think that they would actually benefit from empiric TB treatment. The last recommendation in the paper, we recommended enhanced implementation of the 2007 WHO guidelines, but the 2016 consolidated ART guidelines have now been released, and they have an updated algorithm that also includes GeneXpert and urine LAM in the algorithm. So as I end my talk, I'd like to acknowledge all the groups of people that made this study possible, especially the patients and the staff of the National Referral Hospital, as well as the National TB Lab that did all our mycobacterial cultures, and the study personnel that conducted the study, as well as the PART program that supported the dissemination of our findings. Thank you so much.
Many thanks, Wenceslaus. That was a very thrilling presentation. Are there any questions to the presenter? Yes. I can see somebody, perhaps we'll give a chance to the person fed at the back. Over to you.
This is just really quick. My name is Sean Kavanaugh. I'm the TB technical advisor up at PEPFAR. I saw in your protocol you drew blood, right? Did you biobank those blood specimens? Are you able to do other tests on them?
Yes, actually this was an estate study in a much larger study, and all the samples were biobanked.
Because, I mean, there's, those two studies put together are very curious, right? And there's an idea from the first study that either TB was present and killed the patients, and maybe it wasn't adequately being treated, and you wonder in that case if the drug levels were sufficient, or TB was or was not present, but another pathogen killed the patients. And it might be interesting to do some investigations to see what the co-infections were, or ultimately, if you were able to do drug levels, that would shed a lot more light on the two studies together.
Sure. Yes, maybe just to supplement something on that, our study population was really severely immunosuppressed with a median CD4 cell count of 72 cells per microliter. At this CD4, any opportunistic infection can really infect the patient. So by the time they actually present to hospital, they typically have more than one opportunistic infection. And a small percentage actually of our study patients also had PCP and Kaposi sarcoma, pulmonary Kaposi sarcoma. Yeah, thank you so much.
Thank you. Thank you to you. I think we have run out of time. Please keep your question to the final 15 or 10-minute session. At this point, I would like to hand over to my co-chair, Haile Jesus.
Thanks. I hope we'll have time to discuss these issues at the end of our session. So the next speaker is Charles Sandy, who is working with the Ministry of Health of Zimbabwe, and he will be presenting on the strategies to HIV-associated TB mortality are only as good as their implementation. Lessons from Zimbabwe. Charles.
Thank you very much, and good afternoon, ladies and gentlemen. I'm going to present more from the programmatic aspect, the issues related to HIV-associated TB mortality, sharing our experiences from Zimbabwe. The presentation will be structured with a little bit of background about Zimbabwe first, then we'll go on into some findings from some operations research that we did in trying to identify what are the key issues which are causing our patients to die. So for those of you who don't know, Zimbabwe is a Southern African country, is 14 million inhabitants, more males than females, and more rural population than urban population. We have got the honor of being one of the 8 countries in Africa which belong to all the 30 high burden lists for TB, TB-HIV, and drug-resistant TB. So our TB is driven by HIV, and we see that our treatment outcomes have remained quite suboptimal because of a lot of people who die whilst they are on treatment. Our service provision is provided as an integrated care package through the primary care delivery system. We currently have a strategic plan which aims to see us free of TB, and we have goals and objectives which are aligned to reducing incidence and mortality from TB. This is just a snapshot of the key indicators for TB in the country, and I think of note is that we have reached a treatment coverage rate of 72%, and we also have treatment success of 81%. But of concern on this side, sorry, is no, what? I wanted the light. Okay. So of concern is this side where we were trying to do a cascade analysis of what happens to our patients. And from those whom we estimate to have a pool of presumptive TB cases, we end up screening just a small percentage of them. And we think we are missing out a lot in our routine health services when it comes to screening of presumptive TB cases. And in the end, this will lead us to detecting less cases. So I think we just keep this in mind as it will feed in onto some of the discussion issues that will come up later. Now, just to highlight in terms of the TB strategy, what is it that we need to think of when we are doing TB-HIV? We have TB-HIV embedded in most of the elements of the TB strategy. The aspect of early diagnosis and access to DST, the collaborative TB-HIV activities, and also the preventive therapy, especially now that we are providing IPT to TB-HIV patients. Now, moving on to the study which was conducted last year. This was mainly a records review, looking at the data that we have in our records. And the rationale behind this was that we're seeing our failure to meet the 85% threshold. Our mortality was 8% in 2013 versus a target of below 5%. And when you look at the data by provincial level, we found that most of the mortality was in the southern part of the country. So the southern part of the country contains Bulawayo City, which is our second largest city, Matabeleland North and Matabeleland South. And this is where Rita Drotlo comes from. So she's also coming from high mortality region. Anyway, we have seen that the same provinces over the years have remained to have a very high mortality. And our study was to try to come up with what are the baseline patient characteristics, what are the factors associated with mortality, and what is the timing to mortality amongst registered patients assessing treatment from January to December in 2013. Whilst we were focusing on 3 provinces, we zeroed into 3 districts in those 3 provinces which had the highest mortality because we couldn't do all the districts. It was a retrospective study design, and we had a minimum of 1,971 patients, and the main method was to abstract data from the district TB registers and also data from the ART registers. Our system is still paper-based, so it was a lot of intense effort to look at those records. In terms of the current ART eligibility criteria by then, it was based on the 2013 National ART Guidelines, and ART was being initiated at least after waiting for 2 weeks when TB treatment had been started, regardless of CD4 count. But for those who were severely ill, ART would be initiated at, if it's CD4 below 50 per ml. Also, I would just like to highlight that our current policy now is moving away from CD4 count monitoring. We are now moving towards viral load for monitoring of patients. So, in terms of the characteristics of the patients that were part of the study, the majority of them were males, and the majority were in the 15 to 44-year age group. this is also the age group which is mainly affected by HIV. We also wanted to find or elicit a history of travel outside South Africa, because our thoughts initially were that there was a lot of cross-border movement, and these people were dying because they had gone to South Africa or to Botswana, and by the time they came back home, they would be too ill. However, from the records, it was not all that prominent, though of course we can't say that this is the reality. It depends on how the history taking was being done by the time the patients were being attended to. Most of the patients were from the rural clinics, 47%, and followed by rural mission hospitals, as well as district or provincial hospitals. So most of the patients were actually in the rural setting, with only 14% from the urban polyclinics. In terms of the type of TB, the majority of the cases had new TB, but also quite a significant proportion was retreatment. And in terms of the type of TB, it was mainly the smear-negative TB. And in terms of retreatments, it was the retreatment others which was predominant. We managed to test almost, or to have almost of them having an HIV test result. And we had the majority, 78%, being HIV positive. And looking at the baseline CD4 count, we didn't have data for all the patients in terms of their CD4 count, but we had for about 364 patients, and in general, of those that we had CD4 count, it was low. It was low, and when you look at ART initiation, the majority were ART was initiated in less than 2 weeks post-TB treatment. Now, looking at the overall treatment outcomes, there was a very high rate of patients who were dying on treatment in this group, 22%. Loss to follow-up was low, at 4%, and failures were also low. So the major problem was still dying whilst on treatment as the significant outcome. Now, looking at some of the factors which were associated with mortality, we found that being elderly was associated with the high mortality. And then also the type of health facility where the patient got their treatment, being in a rural or in an urban polyclinic, was associated with survival. So this brings to mind the issues related to the quality of care that we are providing in our facilities. Then looking at the survival, I think about 50% of sorry, I can't remember what I wanted to say. But this is the survival by HIV status, and the first this is HIV negative, and this is HIV positive without ART. And this is HIV positive on ART. So, as you can see, almost 50% of people who are not on ART will end up sort of dying within 2 months. So this is just to really emphasize the point of early initiation of ART. So in terms of trying to summarize all the findings that we got, we found that mortality was 22% overall of all the patients started on ART. There was high mortality among the patients, and this was associated with HIV co-infection, being on retreatment, having age above 65, and late presentation or with advanced HIV disease, and delayed initiation on ART or TB treatment. The retreatments may also be linked to delays in diagnosing drug-resistant TB. Whilst increasing CD4 cell count and being on ART was protective of mortality, so was initiation of TB treatment after 2 weeks of the intensive phase of TB therapy. There was increased risk of mortality amongst those who were started on TB treatment within 3 months of starting ART, and we suspect that this could be undiagnosed iris. So iris is one of those conditions which we sometimes don't really manage effectively because we have decentralized ART initiation to nurses, and sometimes some of these skills on how to identify these complications early are not usually available. So in terms of the messages that we took as a program, what we think we need to focus on is how do we strengthen early case finding and initiation of treatment for both HIV and TB. And what we seem to see is that we need to improve early treatment-seeking behavior. There is this fear of sometimes of health facilities amongst communities, and they would love to come to us as a last resort after having gone to the traditional healers, to churches, to prophets, and the like. So we need to change that mindset so that people come to our facilities first and get treated early. We also need to make our health services more accessible by removing all the barriers to TB and HIV screening. Patients still have to incur out-of-pocket expenditures to get transport to the facility. They need the facility before they are diagnosed. They also have to pay some money for a card, either for if it's for HIV testing, they have to pay money for a card. If it's for TB, they have to pay money for a card, and that can be a barrier to our patients who are generally poor. Then we also need to enhance the quality of the screening by using more effective screening tools rather than just the symptom screen. We also conducted a national TB prevalence survey, and this showed us that up to 60% of our TB cases in the survey were asymptomatic. And if you mix in with HIV, it also means that probably we could be missing a lot just by using the routine screening that we are used to. We also need to strengthen the adherence support that we provide to our patients so that they have better outcomes. Patients suffer when they take the drugs that we provide because they don't have enough food. Sometimes they are vomiting. Sometimes they have to look after their families. And we are not in a position to provide that support, and we need, as a program, then to explore how best can we improve our support to patients. So I would not like to acknowledge all those listed here who participated in doing the review of the records. I think that's all. Thank you.
Thank you, Charles. We have time for one question, if there is anyone having a question. Yes, please. No, go on. What do you say?
My question to the guy from Uganda.
No, that one is later on. It's only for Charles for the presentation. Okay? Thank you, Charles. So the last but not the least presenter, because she is the one who organized this session, is Annabelle Barley. She works in the global TB program of WHO in handling TB-HIV issues. Annabelle.
Good afternoon, everybody. So I'm going to give a quick overview of the WHO TB-HIV policy, which I hope you all are aware of, a very crude gap analysis, and then TB-HIV highlights of the 2016 consolidated guidelines. And I just want to say that we've got a few USB sticks of the guidelines, and we've also got the latest HIV guidelines in the booth downstairs. So you can pick those up later. So as many of you probably know, the TB-HIV policy, interim policy in was brought out in 2004. This was updated in 2012. And it's largely based on three objectives. One is to get the TB and HIV programs working together to provide integrated care for patients, to reduce the burden of TB amongst people living with HIV through early initiation of ART and the 3 I's, and also to reduce the burden of HIV amongst presumptive and diagnosed TB patients. And these have all been incorporated within the latest guidelines for HIV, which came out in 2016. So there are a few updates, as I said, and scale up of these activities have been estimated to have saved 6.5 million lives since 2005. So there has been scale up and there has been progress. However, there's quite a few gaps left, and these need to be worked on. So as you can see from this slide, of reported TB cases, we're asking for that all cases or all people who are living with TB are screened, are tested for HIV. This is not happening. So only 55% were tested or reported tested in 2015. That leaves a massive 45% notified TB cases with no known HIV status. And then if you look at the comparison between the total estimated cases, which is the bar in the middle, with those reported cases, HIV-positive TB cases, only 50% or more than 50% were not reported. So that again leaves a big gap. And then of those, there were a further 20% who were not put on ART. And then not included within this cascade here was also the quite low coverage of isoniazid preventive therapy amongst people living with HIV newly enrolled in care. And in 2015, 21 out of the 30 high-burden countries did not report on it. Now, it may mean that it doesn't necessarily mean they weren't implementing, but that's another one. As well as all the people living with HIV who, I think 40% of all estimated cases were not on ART. So in the new guidelines, obviously, we've been trying to focus on expediting this TB diagnosis, because I think by this stage, you're understanding, I think we're all repeating the same thing. It's not being diagnosed early enough. And obviously, we've brought over the recommendations for the use of WHO-recommended rapid diagnostic tests like Expert as the initial diagnostic test for people who have presumed HIV-associated TB. And we're also putting further emphasis on the need for strategic placement of these machines within HIV healthcare settings. We've also got to think in the future with the great opportunity for multi-use, for early infant diagnostics, for viral load testing, and also for the use in viral hepatitis. The really very careful placement of these machines to make sure that TB doesn't lose out, because there's going to be competition. And so we need to make sure that through adequate placement in the right facilities and also with capacity building and training of staff, that they're used for the right purposes, or appropriately, let's say. So the new guidelines also focuses on the seriously ill patients, and as Wenceslas highlighted in his presentation, we've defined seriously ill with the 4 danger signs: unable to walk unaided, respiratory rate of over 30 breaths per minute, fever of more than 39 degrees, and a pulse rate of over 120 per minute. So the recommendations from the 2015 LF-LAM for seriously ill patients living with HIV have been incorporated within the guidelines. And these recommendations are for the use of for assisting TB diagnosis in adults and children, for those with CD4 counts of less than or equal to 100, or seriously ill regardless of CD4 counts. And these can be used in both inpatient and outpatient facilities, but they must have, they must be seriously ill. So you can see here from the pooled analysis that the sensitivity increases with the reduction in CD4 count, as well as with higher severity of illness. And a recent study that was published in The Lancet earlier this year showed that it was a very interesting study randomizing patients for diagnosis, but with nurses doing the testing. One arm was standard diagnostic tools. The other arm was standard diagnostic tools plus LF-LAM. And the nurses actually made the decisions based on the results, the positive results, and there was an association with reduced mortality as a result of this. So this also shows the possibility of being able to task shift to peripheral facilities. So for presumptive TB treatment now, we've had a bit of a debate really this afternoon about this. We've got one side saying, oh, it doesn't work. The other side says it does. Well, I mean, obviously, we actually reviewed the evidence for the guidelines, and we could not find evidence. In fact, at the time, the results from the REMEMBER trial were out. We could not find evidence to show the benefit of providing presumptive TB treatment for people living with HIV with no symptoms. But it was agreed that we need to continue the recommendation from the 2007 guidelines, showing that if the patients have danger signs, they should have presumptive TB treatment, and this is best clinical practice. So here's the algorithm that's been updated since the 2007 guidelines, and you can see the recommendations of danger signs there. There's expert incorporated within there, and LF-LAM is also neatly fitted in within. So going on to timing of ART, for the 8 high-quality evidence from 8 trials were reviewed for the optimal timing of ART for HIV-associated TB, and these found that there was definitely reduced mortality amongst patients who were provided ART within 8 weeks of start of TB treatment compared with after TB treatment, after 8 weeks of TB treatment. So the recommendations have stayed exactly the same as previously, but they've been upgraded to high-quality evidence. And likewise, similarly, the evidence was reviewed on the timing of ART for patients with CD4 count of less than 50, and it was also recommended that the same recommendation for within 2 weeks is continued from the last recommendations. So the highlight of the HIV guidelines has been really, and the excitement that has been buzzing throughout the HIV world, is that ART can now be provided, should now be provided to everybody regardless of CD4 count. And this was based on a number of studies, as well as 2 trials, the START and Temprano trial. And the Temprano trial here, you can see the reduction in tuberculosis from ART alone by half. And that's basically compared with the current existing guidelines that WHO had at the time, compared with immediate ART at time of diagnosis. So that shows a real impact on tuberculosis prevention. But you can see here that they also brought in isoniazid preventive therapy. And you can see actually, it's not so much a dose response, but you can see the reduction. If you see the top line is deferred ART, and that means, and the probability of death is much higher, then deferred plus IPT is just a little bit lower, and so it carries on. So the black line, the lowest line, is early ART and early IPT. And it basically showed that IPT independently decreases the risk of morbidity. And this severe morbidity, which was their combined endpoint of death or AIDS. So this really shows that IPT has to be given for patients on ART. In the context of ART scale-up, countries are all wondering, should we be considering IPT as well? And you should. So in conclusion, the screening tools may not be ideal, but there are the ones that we've got out there can make an impact on mortality, and we really need to work to scale those up. ART within 2 to 8 weeks of start of treatment really does save lives. We've now got every overwhelming evidence to show it, and ART alone is not enough to prevent TB, so scale-up of treatment of latent TB infection is urgently needed. Thanks very much.
Thank you. Thank you very much. So now the floor is open actually for all speakers. We have barely 7-8 minutes, so anyone for Annabelle and for any of the speakers, the floor is open. So Asma, you were having a question, right? And please indicate to which speaker you are asking the question.
Yeah, I had a question, but Annabelle answered it.
Okay.
Because, the guy from Uganda, I just thought, are you happy about the methodology you used in your study? Because if you had 3 arms across the CD4 with and without danger signs, it would have been more informative to, program managers. But Annabelle just responded to the query I had. Yeah.
Next question.
Hi, Stephen Lassen from Liverpool. Just to reopen the can of worms that is presumptive treatment in TB, do you think with the current, I think this is mainly to Annabelle, within the current TB guidelines, the current WHO guidelines, there's a suggestion that you wait for 3 or 5 days following the initiation of antibacterial treatment before initiating TB therapy. Do you think in the sickest patients, you may indeed have like a mycobacteremia or TB sepsis, that you're actually missing, you're having very early mortality, that you might be missing an opportunity to treat? And secondly, because there's co-infection maybe with TB and bacteria, that the apparent response to antibacterials might be falsely reassuring.
Okay.
Can you? Okay.
Massini from Kenya. Question also to.
First, let's answer the question, and you can come, Massini, later. Okay. One at a time. You can put the algorithm on.
I'll try and answer that. I think. Certainly, I think the antibacterial antibacterial trial is really aimed at pneumonia. And that's a real killer, and I think that needs to be got out of the way first. So, I mean, I guess there are tensions when these are very severely sick people, and you have to make those clinical decisions on the spot, I think, to a certain extent. But the trial, the antibacterial, broad-spectrum antibacterial trial, is actually based on evidence from way back 2007, I think, when the guidelines were initially, and it's still, I don't know.
Yeah, but I think the point is, any clinician, when you are really handling someone with acute respiratory distress and, running fever and suspecting really TB, what comes to mind is really to save life and to do whatever investigation you have and whatever, intervention you could. And in the background of potential TB and a possibility of bacterial pneumonia. So if you see the revised algorithm, actually, that's why we also now included urine LAM as one of those tests, because you can get the test result in those type of patients in 20 minutes. So that at least, even if it is not confirmatory test, it can help the clinical decision-making, the clinical judgment, so that when the clinician prescribe anti-TB drug, they could be somewhat, at comfort that they are treating TB. Fortunately, anti-TB drugs could also cover for broader, bacterial pneumonia from clinical practice. So that is why we are proposing like that. It's a matter of emergency, really saving lives.
I don't think I was suggesting the absence of an antibacterial trial. I think I was suggesting it in combination with TB treatment. And I guess from the post-mortem studies, we're clearly missing lots of cases. And I don't know whether the analogy really applies, but certainly in sepsis, your attitude would be to start very broadly. And if you've got, people who are ostensibly presented with pneumonia, maybe 30, 40% of them could indeed have TB. Maybe you're missing opportunities. Anyway.
Okay. You want to say something?
Yeah. I just want to make something a bit clearer, just to make sure that everyone understood, is that the trial that we did was to see whether we could expand the use of empiric TB treatment. And it just showed that if we expanded, there is no benefit. But definitely people who have danger signs, they were not even included in this study, because it was important that they are all started on empiric TB treatment. So because we had a control arm and an intervention arm, we did not want to include anyone with danger signs. So please don't misunderstand that we were saying that empiric TB treatment doesn't work. What we were looking at was with the possibility of expanding TB treatment to a much larger group than what we're currently talking about. And unfortunately, the results showed that it wasn't helpful. And unfortunately, if you look at it, it was due to delays in the ART treatment. So it's possible that there was still some benefit, but just that because it delayed ART treatment, the benefits were cancelled. So I just hope people understand that there's definitely not a movement against empiric TB treatment. We were just trying to see whether we can do more of it.
So I think you are also bringing a very important point of, what is the definition of, empiric or presumptive TB treatment. What we used consistently in the updated HIV guideline is presumptive TB treatment. And this is a treatment that is given to someone, a clinician is suspected to have TB without confirmation, without any investigation or without confirmatory test. So we still look for studies that really look into this presumptive TB treatment application to save lives. So the empiric TB treatment definition, actually, that is why we did the systematic review. We reviewed 3 or 4 studies. None of those studies actually qualify to our definition of presumptive TB treatment. So if there are researchers in this room, my plea will be really to go into that presumptive TB treatment and to look in the situations where we have, especially now we have urine LAM that can give us some, a sense of confirmation. Massini.
Thank you. And thank you, the speakers, for the informative presentations. My question is to probably Annabelle and to guide in policy formulation for countries like Kenya, who probably by the end of this year, nearly all the patients who are in HIV care would have gone through IPT for 6 months. Should we now continue only for those newly enrolled, or what happens in terms of policy? We know IPT is not lifelong, but we also know there's the shorter rifampicin-based regimens coming up. So what happens next?
I think this is now a good point which we are looking into, because currently we are consolidating our guidelines around TB prevention, for both HIV positives and HIV negatives, and that is something which we will critically look, because this is also coming from many program managers, because now more countries are putting patients on IPT and also on ART. And the challenge we have is we don't have a policy of recurrent IPT. If IPT is given once during that reporting period, it has to be reported for that time. But how we can reconcile with what is happening in practice when more and more people are on ART, and also probably getting it twice in the 3, 4, 5 years, lifetime, they are having antiretroviral. I think we are looking into that. Back. Can you use the mic?
Yeah, can you hear me? No. It's not on? There
now
it is.
It's on.
Okay. Hi, I'm Christina Yoon. I'm from UCSF. I have a question for the WHO people. I think that, and I'm just shifting the conversation back to empiric TB treatment. I vote for more empiric TB treatment. I think that has the WHO or any kind of policymakers considered simplifying the algorithm, or the algorithm for how, which patients are chosen for empiric treatment? Specifically, I get the need for danger signs in the outpatient setting, but in the inpatient setting, I think that we could all pretty much argue that all of those patients, because they require hospitalization, meet criteria for danger signs anyway. So why not then simplify the algorithm for patients who are hospitalized for respiratory symptoms or hospitalized with presumptive TB, and just say all those patients should be empirically treated for TB, unless an alternate non-TB disease has been identified?
Yeah, but the algorithm is also applicable not for patients being treated in hospitals. It's also in peripheral settings. And even the recommendation is to refer them to hospitals or to higher facility. But in the situation when that is not possible, they have to put them on that presumptive treatment. That's what the policy says.
Right, but then to separate, the indications for empiric treatment for outpatients with danger signs and then with inpatients, right? Because if you're looking, some of the studies show 20, 30% inpatient hospital mortality for patients with HIV-TB. Those are approaching numbers, inpatient mortality numbers for sepsis in ICU patients, right? And I think someone mentioned earlier that those patients would be empirically treated.
Okay, Meg, you want to comment?
No, I just want to add, I think that that's the idea of this sort of advanced disease package, which could be used in an outpatient setting or an inpatient setting, and it addresses some of those questions about, well, you have to cover all your bases. And if you looked at the reality trial, they covered fungal, they covered bacterial, they covered parasitic, as well as tuberculosis. And in that trial, it was people without symptoms, but still without any danger signs, but with a very low CD4. Now the question is, if you have danger signs, TB symptoms, and the low CD4, would it be TB treatment rather than prevention in that package of care with a series of other potentially bacterial, fungal treatment infection? And I think it's about ensuring that that's given as a package to fast track, and certainly there shouldn't be a staging of these. They should come on all at once and then manage the side effects. as hard as that may seem and sound. But that's, I think, the idea. It's like trying to get antibiotics into somebody within X hours that we have to do if somebody presents with sepsis. And I think that's the idea. Yeah.
Thank you. Thanks.
Hi, I'm Andrea Howard from ICAP, and this is also for WHO, and I'd like you to comment on the continued role of CD4 count at HIV diagnosis, particularly in the era of test and start and routine viral load monitoring to identify individuals who should start ART really immediately and people at risk for other opportunistic illnesses. We saw in one of the presentations that most TB-HIV patients don't routinely have CD4 measured.
Okay.
So I think this is one of the classic questions we are asked all the time. So what does it mean? And we try to address this there is a public health approach, but there's also clinical management. And in our guidelines, we say the CD4 is a very good clinical tool, like a hemoglobin, like a syphilis test, et cetera. And when we did what we called a Delphi consensus statement, so we brought this to a broader group to say, do we need the CD4 and when at baseline? And the sense was right now, especially in this transition to viral load, scale up, et cetera, and not having an alternative test that would be rapid and point of care that might be sort of at a threshold, high CD4, low CD4. When we don't have that, having a baseline CD4 is important to help identify those people who would need this rapid package for advanced disease. Now, we know that there's lots of places like Malawi and others who don't want to invest in CD4. They never have. What should they do? And I think that becomes a much more difficult situation because it's going to be based upon clinical presentations, and we know that there are issues that physical presentations may miss some people who really do need a fast-track approach. Viral load is not yet fully scaled up, and we have said clearly in our guidelines that viral load is our preferred measure for monitoring treatment, and that was in 2013, and again now. We do not recommend the use of CD4 for monitoring. Now, the problem is some countries are really struggling with, until we have viral load scaled up and access to greater than 75% of our patients, can CD4 help us in the meantime with monitoring? And we would say that should be a limited time scale and primarily for clinical use. Now, if we could have a rapid CD4 that tells us higher or lower than 100 or higher or lower than 200, I think that would be very useful and something that would be point of care and not just near point of care. Thanks.
So I think we're running out of time. So last question, Lisa.
Okay,
Sorry,
thanks again to everyone.
Jerry.
And I guess
Yeah.
I do really encourage the idea of a rapid package for sick patients and late to care patients. But I guess my takeaway from this is a little different in the sense that I did want to congratulate the colleague from Zimbabwe on his presentation, because I think he showed very clearly that mortality is unacceptably high, that you can use routine program data and drill in. And my takeaway there is ART really made the difference and almost made mortality rates between HIV infected and uninfected equal. And so again, I guess I get back to the question or the point to all of you that I raised earlier. I mean, I also think we need some qualitative research about why are patients coming so late to care in this day and age when really treatment is much more available than it was 10 or 15 years ago. And quite honestly, if they come to the hospital with danger signs and a CD4 count below 50, a lot of them are going to die whether they get presumptive treatment or not. So I guess just for the audience here to think about what are the other factors. You know, we throw out the term stigma and discrimination, but there's also a lot of violence against people living with HIV and key populations who are at risk that is really impeding care-seeking behavior. So I think there's some other factors in play that we also need to look at for reducing mortality.
Thank you. Thank you. That's actually nicely summarizes the discussion. Okay, Jerry, you really want to ask? Okay, just please, because we are well ahead of time.
I'm sorry.
Yeah.
I just want to say there is a point of care CD4 count that gives you an answer in 20 minutes, and it's readily available. You have to make an investment in it, but it's available, and it can do just that in the era of everyone, regardless of CD4 count, getting antiretroviral therapy can tell you which ones need to get it immediately and which ones you don't have to push on. So that can be added to the package, and I think it should be. And I agree completely that these are the patients who need a lot of stuff at the same time. A lot of these patients are dying of bacterial infection, again, dehydration, shock, anemia. These are all standard medicine care for very sick patients that, like in the intensive care unit, really have to be applied to a subset of these patients. I think they should be actually, I like very much the idea of the very high-risk patient stratified by simple measures, vital signs, breathing rate of more than 30, respiratory, et cetera, blood pressure and all, and attention to that, and not all places have it available, many do, I think would be life-saving as well.
Thank you. Thank you very much. So with that, we come to conclusion of the session, and we have seen the challenge basically faced by this late presentation, and I think this idea of looking into what are the reasons for why patients present late. Some of the reasons we already know, but there may be some sociological reasons which we don't. It's good to look into that. And also the discussion around the presumptive TB treatment. And I think the use of antibiotics with anti-TB drugs is something which we have to look into to expedite the treatment. And also, this late presenters package, which is now being generally pushed by the HIV side, could also really be helpful in addressing this issue. So with that, I thank all of you, all the presenters, and have a nice evening.